Good afternoon. My name is Greg Wahlstrom, and I would like to welcome you to the Central Illinois chapter of the American College of Healthcare Executives webinar program, Health Information Exchange Implementation in the Real World. After the webinar, you will be directed to a short survey, which we hope you will take the time to fill out. Today's webinar has been awarded 1.5 hours of qualified education towards your board certification or recertification through the American College of Healthcare Executives. If any IT problems arise, please visit support.anymeeting.com for further assistance. As we begin the presentation, can you please mute your telephone lines until the question and answer portion of the event? On the left-hand side of the webinar platform screen is a text box to write a question to the presenters. If you have a general question, please insert your question into the text box. If you have a specific question for one of the presenters that you would like to ask, please insert his or her name next to your question. Just as a reminder, this webinar is being recorded. We are happy to announce there are many attendees who are listening in from not only here in the United States, but other countries such as India, Italy, Germany, Europe, and even the United States Armed Forces naval carrier off the coast of Atlantic. Today's program, the Office of the National Coordinator, ONC, part of the Department of Human Health Services, has awarded funds as part of its State Health Information Exchange, State HIE, Cooperative Agreement Program. The goal of this program is to support efforts to rapidly build capacity for exchanging health information across the healthcare system, both within and across states. The program moderator and panelists will discuss the expansion and development of new HIEs, which are bringing together local communities and which are then connecting to state networks, including the challenges and lessons learned from technical, governance, engagement, and sustainability point of view. The panelists will also discuss related offerings available to the healthcare systems through the HIE, including strategies to meet the Centers for Medicare and Medicaid meaningful use requirements, and how the health information exchange can be employed to share data transitions of care. Today's topics we will be covering: present current status of implementation of the state or territory's HIE, discuss the successes, challenges, and lessons learned during the founding of the HIE and when onboarding to the state network, examine strategies to use HIE to meet meaningful use requirements at the health system level, understand how health information exchange can be used to facilitate transitions of care, and what elements of cost are included in creating a HIE. How do you make decisions on whom to solicit for membership in the health information exchange? And how does the admit, discharge, or transfer ADT adapt, assist to the health plans? How does the health system benefit from providing this data? And can the ADT data be used for other purposes? What are the incentives and penalties around meeting meaningful use, stage 2? And how do you plan for sustainability? Is the benefit of being able to exchange data electronically worth the cost? And what are the roles HIE play in facilitating the exchange of health data in order to meet meaningful use stage 2? Today's moderator, Dr. Garland, PharmD, HIE Policy Board Member, District of Columbia, HIE Policy Board. Dr. M. Garland Jr., MS PharmD, is an independent consultant based in Washington, D.C. Through DMG Scientific since 2007, he serves organizations in both the public and private sectors domestically and internationally. In the U.S. public sector, he is a mayoral appointed board member of the DCHIE, District of Columbia Health Information Exchange Policy Board. He also advises the district's Department of Health executives on eliminating disparities in infant mortality, working in partnership with the Clinton Global Initiative. In the past 12 months, Dr. Garland has also consulted HHS, SAM, HSA in a policy advisory role on prescription drug abuse, and HHS CMS as a chairperson evaluating recipients for the $1 billion Healthcare Innovation Awards. In the private sector, Dr. Garland serves in project management and advisory roles, both pre-award and post-award, to the state and federal consulting companies and grantees, helping them to increase their customers' return on investment on health and human services related to engagements to include biomedical research, clinical services, organizational and operational improvement, and health media communication projects. In the past 12 months, his clients were awarded over $32 million in competitive bid contracts from the federal and state agencies. Prior to DMG Scientific, Dr. Garland was a GlaxoSmithKline scientist and a genetic engineer and health disparities research in academia, and NIH extramural research scientist with a focus on liver physiology. Our first panelist today is Lauren Wiseman, MSN, Clinical Service Manager, Central Illinois Health Information Exchange. Lauren Wiseman has been involved with the Health Information Exchange efforts in Illinois since 2009, participating in plant grant work groups and then joining the staff of the Central Illinois Health Information Exchange in 2011. Lauren is a registered nurse with more than 30 years of healthcare experience in several clinical settings. This diverse experience has fueled her passion for health information technology and health information exchange. As a clinical service manager, Lauren works with participating healthcare organizations providing clinical project management, promoting effective adoption of HIE, and supporting meaningful use efforts. Successfully implementations include large IDNs, community and critical access hospitals, and independent practices. Prior to joining CHIE, Lauren was a clinical informatics specialist for the Rural Health Center in Clinton, Illinois, leading the EHR implementation and the HRSA Small Rural Health Quality Grant. Lauren is an active member in HIMSS, serving as the Vice Chair, Midwest Region of the Chapter Advocacy Roundtable and the Chapter Advocacy Chair in the Illinois Greater Chicago Chapter. As member of the American Nurses Association, serves as a peer reviewer for continuing education, and in 2012 she was appointed to the Care Coordination Quality Measurement Panel Advisory Committee. She holds a Bachelor's of Science in Nursing from Maryville College and a Master's of Science in Nursing from Duke University. Lauren is board certified in nursing informatics. Our second presenter, Jack Malloy, Vice President, IT Service Integration and Quality and Corporate IT at Henry Ford Health System. Jack Malloy is a senior technology expert reporting to the Chief Information Officer of Henry Ford Health System. With over 35 years of experience in application software systems for healthcare providers, Jack's areas of expertise are strategic planning, system selection and integration, applications portfolio management, and solutions architecture. Jack was the chief architect for Henry Ford's internally developed enterprise-wide revenue cycle and electronic medical record systems. These legacy systems were recently replaced by Epic applications. As part of the Epic implementation, Jack established a strategy and plan for the Henry Ford Health System Information Exchange, HIE, also in partnership with the VP of Performance Management. Jack co-led the development of an enterprise data warehouse program, and in his current role, Jack is responsible for aligning, centralizing, and consolidating IT services across the Henry Ford Health System enterprise to improve service levels and to reduce costs. Our final presenter, Carla Smith, MACNM, FHIMSS, Executive Vice President, HIMSS North America. Carla Smith is Executive Vice President of HIMSS and a global cause-based non-for-profit organization focused on better health through information technology, IT. HIMSS leads efforts to optimize health information and care outcomes using information technology. Within HIMSS, Smith leads HIMSS North America Business Unit. In the capacity, Smith leverages her extensive experience in non-profit management to ensure HIMSS' ability to achieve its mission and maintain its financial health, primarily within the United States and Canada. Smith has 27 years of experience in the information technology field, 2/3 of its focused on healthcare. She champions transformational ideas that positively affect the quality, safety, cost-effectiveness of and across to health and healthcare. In addition to her responsibilities at HIMSS, she holds and appoints to CMS Outreach and Education Federal Advisory Committee, serves on the Board of Directors for the National Stroke Association and the Commission for Accreditation on Health Management Education. As an advisor of the University of Michigan's Health Informatics and Learning Health Systems programs. Before joining HIMSS in 2001, Ms. Smith served for 7 years as the Chief Executive Officer for the Center for Healthcare Informatics Management, CHIM, and worked on IT-related initiatives within the manufacturing and banking industries. She holds a master's degree and has earned a non-for-profit management certification from Case Western Reserve University, as well as her HIMSS Fellow status. Now I would like to take the opportunity to pass the floor over to our moderator, Dr. Garland. Good afternoon.
Good afternoon, Greg, and hello, everyone. Can you hear me just fine, Greg?
Yes, sir.
Wonderful, thank you. Hello, everyone. I'd like to once again welcome you to our webinar today. We have over 350 registrants calling in from 10 countries around the world. Again, my name is Douglas Garland, Managing Director of DMG Scientific, a health systems management consultancy based in Washington, D.C., and a mayoral-appointed board member of the D.C. Health Information Exchange Policy Board, where we are responsible for generating policy recommendations for our nation's capital to establish a functional and youthful HIE. I want to say a word of thanks to Greg Wahlstrom and the Central Illinois chapter of ACHE, the American College of Healthcare Executives. It is an honor to be the moderator of a conversation that we'll have today with national experts on health information exchange. Health information exchange has the powerful potential to improve the quality of care and reduce costs for payers. The technologies that serve as the basis for HIEs across the country can and are enabling clinicians of various professions to better reach their goals. The primary goal by far being our ability to deliver on safe, effective, and efficient care for our patient populations, and do so in a sustainable manner that provides return on investment for any buyers of HIE services. In order to reach these goals, we will need critical insights, perspective, skills, and leadership from across the country. We are delighted to have 3 of these leaders with us today: Ms. Lauren Wiseman, Mr. Jack Malloy, and Ms. Carla Smith. We'll be hearing from each of them in that order. First, we'll hear from Lauren Wiseman. Lauren Wiseman is the Clinical Services Manager and a member of the Central Illinois HIE. Serving 20 counties, the Central Illinois Health Information Exchange provides fast, secure ways to get patient health records from one provider to another. Lauren Wiseman, the floor is yours.
Thank you, Dr. Garland. I appreciate the opportunity to participate as a panelist in this important discussion and share the experience of the Central Illinois Health Information Exchange, or CHIE, as we like to call it. It does save us a little bit of time and a lot of syllables. CHIE is really not the only HIE effort that exists in the state of Illinois. We do have, on the state level, the Illinois Health Information Exchange, and there are other regional efforts that include the metropolitan Chicago area, the northwestern portion of the state, the southernmost region of the state, and then the eastern St. Louis metropolitan area extending into Springfield with the Illinois Health Exchange Partner and Lincoln Land Health Information Exchange. CHIE, as our name suggests, is serving the middle portion of the state. We're based in Peoria, and we have connections that reach from the western border in the Quad Cities to the eastern edge of the state in the Champaign-Urbana area. As a regional network of participating healthcare organizations, we've had data contributions from our initial connections since mid 2012. We have over 45 hospitals, 350 primary and specialty care physician offices, and more than 35 long-term care facilities as current participants. This yields much more than 2.5 million patient records that are currently available by query. And we are an alpha partner with the state of Illinois HIE. I think the saying goes, if you've seen one HIE, you've seen one HIE. Every journey is unique, and HIE's journey has really been a grassroots effort that began in 2009 with a planning grant from the Department of Healthcare and Family Services. HIE didn't exist in Illinois at that point in time, and HFS divided the state into 16 medical trading areas. Each MTA received funding to develop a plan for HIE in their area. So the MTAs that contain the communities of Peoria, Bloomington-Normal, Decatur, and Champaign-Urbana pooled their funding and their resources to work together to develop a plan. This collaboration actually provided diverse stakeholder participation, not only in the types of organizations that were involved, but the roles of the volunteers from those organizations. We had laboratories, pharmacies, large hospital networks, critical access hospitals, federally qualified health centers, as well as payers participating. We were able to convene 6 topic-specific work groups that looked at all aspects of health information exchange and convened clinician and consumer focus groups to gain their perspective with oversight from an executive leadership committee. The result of that planning was that we had a very clear vision of how health information exchange should look in Illinois. With all of this input, it was decided that we wanted to have data sharing and collaboration in a longitudinal patient community record. But what was really needed was the commitment as well as the vision and investment to make this happen. So in 2011, we had 11 hospitals and 4 specialty clinics who provided the initial investment and became our charter members. That allowed us to establish ourselves as a nonprofit organization, select a vendor, and put into place the legal agreement, policies, and procedures that would be necessary to share data. After our launch in 2012 with our first connections, we utilized some showcases to provide examples of the best use of health information exchange, and we've continued to add data sources and connections in the following years. We've recently had HIE to HIE connections and the development of that direct trust connectivity that allows us to communicate not only within our region, but to other regionals, the state, and indeed any direct trust participant across the nation. Of course, we faced a lot of challenges in trying to make health information exchange happen. We were the first connected health information exchange in Illinois, and while those challenges are also interesting, they are also ongoing. We really do rely on our participants to support us in all of these challenges, privacy and security especially. It was a decision early on regarding privacy that the exchange made to follow an opt-in or an opt-out policy. And it was decided that we would have an opt-out policy. Otherwise, unless a patient made a decision to opt out, they would be automatically included in the exchange. And of course, the recent media focus on security breaches has really been enough to keep any security officer up at night. But it is something that we continue to have to be vigilant about. The data integrity really refers not only to the accuracy and quality of data, but to the completeness of the data. And it is, again, something that we rely heavily upon our participants to ensure that that they improve clinical documentation to its best quality, and we continue to connect the sharing partners that is important for them to share their data. Standards continue to be a challenge because there are so many of them. I think that the options that are offered are good for a free market, but for the industry, it's been a challenge to discern the way that all of the vendors are going, and sometimes impedes the efforts to be able to exchange data in a cost-effective manner. Metrics continue to be a challenge because it is difficult to determine the impact that health information exchange and the data and how the data is used to affect an outcome. Some of the early studies have indicated that there is cost savings when HIE is utilized in an emergency department, but a recent systemic review of the studies that was conducted by the RAND Corporation has really led to the belief that much more study is needed in order to determine what the return on investment is and what the value of health information exchange can be. All of our healthcare participants and all of the health organizations really have a lot of competing priorities. We have had connected organizations who have migrated to new EHR vendors. Most of them have moved to the 2014 certified version of electronic health technology. And of course, ICD-10 and other compliance and regulatory issues do compete for attention, both of the clinical staff and of the IT staff that are responsible for the connections. And I think it's very important with all of the efforts that are going on through the state and the regionals that there is an alignment, that we can provide the opportunity for every healthcare organization or provider to be connected to health information exchange without duplication of services or competition. What we've learned from these challenges and these experiences is that, you know, when we look back, the opt-out decision might have been relatively easy, and we did determine that we wanted to make sure that patients were notified of organizations' participation in health information exchange, but we really needed consensus on the implementation of that process. It was very important to all of our participants that there was a consistent message across the communities, that they heard the same thing from all of the healthcare providers that were participating, and that we had a level that everyone could agree on the notification without impeding the throughput of the patient through the organization. It also does take quite a bit of time to build a foundational data infrastructure, and trying to promote the adoption of health information exchange and utilization by clinicians really needs to be considered, and make sure that you have enough data to really support the decisions, to provide information to support decisions for the treatment with the physicians. I think the best success that we can have is focusing on the implementation efforts in community by community, so that there is robust sharing within that community to provide the clinicians the data they need. And then as technology continues to evolve, all of our connections are an ongoing process with, again, the migration to new electronic health records, with the type of rapid development that continues within that technology, and just making sure as an organization that we know where our participants are, that we are monitoring and testing those connections continuously. There are several strategies that health information exchange can be utilized to meet meaningful use requirements. Because of our partnership with the State of Illinois HIE, we are able to offer public health reporting to our participants with the single connection. Other HIEs and HIOs across the nation have offered examples of quality reporting, registries, order results, and patient engagement, or personal health records connectivity that are other strategies and under consideration by Central Illinois. I think one of the most significant strategies is a result of transitions of care. What we know from the literature is that patients are at their highest risk for an adverse event or a readmission during the transition from one care setting to another. And complex patients really do need multiple points of care from multiple specialists, and there's opportunities for fragmented care from gaps in communication. In fact, a study done in 2013 by Berkowitz and Anderson indicated that Medicare beneficiaries with 10 or more chronic conditions were 6 times more likely to be readmitted. And while they represented less than 9% of all Medicare beneficiaries, they were responsible for more than 50% of all readmissions. So clearly, there is efforts to be made to improve communication in the transitions of care. And that really is beyond just the technical connections that can happen with an integrated CCD sharing or query experience that the HIE can technically provide. We also offer as a neutral table for collaboration, for building community trust, to help our participants connect with their important sharing partners and provide outreach and education to those organizations that were not included within the EHR incentive. So long-term care, behavioral health, smaller organizations that have not yet adopted EHR technology. Those are our focus, and that is how we try to make sure that we are helping our participants. Lastly, I was asked to talk a little bit about the cost in setting up an HIE. And I think when you look at the budget for a typical HIE, you're going to see the types of line items that you'd expect related to technical issues and hardware and software, operationally with staffing, accounting, insurance, and of course, legal costs are pretty extensive, especially during the startup phase when the contracts are being connected or created. But every HIO is going to have to determine for themselves exactly how those costs are going to play out and what participants will be charged. In Central Illinois, our board spent a great deal of time looking at how much it was going to cost on an annual basis to operate the exchange, and then how to proportionately allocate the cost across our entire community, keeping in mind consideration of all the different types of organizations that were members. We do not receive federal or state fundings to support our operations, so it's very important to know what the costs are going to be and how our participant engagement is going to cover those costs to meet the goal of financial sustainability. That's probably true of the federally funded organizations, and in a lot of ways at FHIMSS, we feel kind of blessed that we had to navigate this and figure this out ahead of the creation of the HIE. So, Dr. Garland, it's back to you.
Wonderful. Thank you, Lauren. So we have 2 questions for you, please, Lauren. Major HIE stakeholders have often included the clinicians and payers. However, in pursuit of innovations from a technical perspective, would you please advise us on how you have included technology vendors, software and hardware, in the conversation at a local level? Thank you.
Well, I guess from an early example would be the decision that the board reached to host the infrastructure for the databases locally within the Peoria region. If you think back to when we were first beginning, it was kind of the middle, maybe towards the end of the recession. So it was very important to support the local community economy by hosting that portion of the health information exchange with the local market.
Wonderful, thank you. And a second question, you mentioned data integrity as being a potential challenge. Indeed, while clinicians may use various guidelines for best practices on care, at times there are differences in medical opinions, sometimes based on anecdotal evidence. So would you be able to counsel clinicians to use HIE for population health versus personalized medicine? How would you provide them advice on using the HIE for population health versus personalized medicine?
Well, that's an excellent question. I think it's important to understand that the health information exchange workflow has been really challenging to incorporate for clinicians, and I think they can look at it a couple of ways. It's probably not necessary for every encounter to be part of an HIE query. For your average, normal, healthy patient, there probably isn't a great deal of data within the HIE that would influence any treatment decision, but I think that clinicians can look at either age-specific or disease-specific populations and then really focus any effort that they have with the health information exchange on those patients to assist them as they try to make the best decisions possible.
Thank you, Ms. Wiseman. Next, we'll be hearing from Jack Malloy, Vice President of IT Service Integration and Quality for Henry Ford Health System. Founded in 1915, Henry Ford Health System is committed to improving the health and well-being of a diverse Michigan community. Jack Malloy, the floor is yours.
Well, thank you very much, Dr. Garland, and good morning, good afternoon, and good evening to all the participants out there. I appreciate the opportunity to share Henry Ford's experience with Health Information Exchange on an international platform, and looking forward to your reactions and your questions later. So as Dr. Garland said, Henry Ford Hospital, Henry Ford Health System opened as Henry Ford Hospital back in 1915. We're celebrating our centennial. It was opened by Henry Ford himself, the auto pioneer, and it was modeled after the Mayo Clinic, which was not just a hospital, but also included an employed medical group, an employed medical staff. Since then, we've grown to 5 hospitals and 29 different medical centers that we own. The flagship hospital, Henry Ford Hospital, is still a staff model, closed staff model, so it is staffed by our Henry Ford Medical Group physicians. The other hospitals that we have, some were acquired, and so they are community hospitals. We have affiliations with private practices in the communities who admit into those hospitals. As you can see from our numbers here, we have over 1,200 physicians within the employed Henry Ford Medical Group. Within our clinically integrated physician network, which includes the medical group as well as our affiliated practices, we have over 1,700 physicians. And we also have one of the largest residency programs in the nation that's not connected to a university or a school of medicine, with over 1,900 medical students. It's not well known, but we also have a health plan, Health Alliance plan, and we're very proud to say that we were the recipient, the 2011 recipient of the Malcolm Baldrige Award for quality. Some facts and figures. As you can see here, the ones that I would like to focus on are the fact that we do over $60 million in research every year. And another fact that's very critical to this presentation, and by the way, these are all 2013 numbers. The 2014 authorized numbers haven't been released yet. But in 2013, as you can see, even though we had over $4.5 billion of revenue, we only had net income of $500,000. So as you can see, that's 0.01% or 1/100%. So we're running on very slim margins. This is a picture that we use at Henry Ford to describe the 4 major data sharing capabilities in our HIE strategy. I think it was mentioned in my bio that we recently went to Epic applications for revenue cycle and for clinical, and it's across all of our hospitals, medical centers, and Epic has some great capabilities for data sharing. The strategy, I would say, could best be described as fire in every direction, because as you can see, we've got multiple approaches of data sharing, and the reason for that is that our healthcare partners have different needs, different workflows, and different technology capabilities. And so our goal is to try to connect wherever we can and however we can. Unfortunately, this technology or data sharing environment is somewhat complicated. And so, you know, the saying is that a picture is worth 1,000 words. This is the picture that we use to try to explain a complicated situation to our physician and senior executive leadership. It's come to be known as the Mickey Mouse diagram here at Henry Ford for obvious reasons. Starting in the northeast quadrant there, so if this were a clock, it would be about 1:30. The one capability that Epic gives us is called Community Connect. And with Community Connect, we can actually extend our Epic application to our affiliated providers so that they can run their practice on it. It involves sharing the same clinical record, but the revenue cycle or the billing data is walled off so that that is hidden from everyone else. We've had some fairly good success with our Community Connect application in our extension. We have a few dozen providers, physician practices that use our Epic system in that way. Epic also allows us to extend Community Connect or our Epic system through Community Connect to other hospitals as well, but we haven't really initiated that activity yet. So moving counterclockwise, if we go to the northwest quadrant there, Epic gives us a tool called Epic Care Link. And what Epic Care Link is it's a web portal that allows providers, affiliated providers, to log into our Epic system and transact business with us. They can either send us a referral, they can send us orders, they can look at their patients. We have a number of patients that we get from the northern part of Michigan. Practices up there don't have organ transplant facilities, and many of them will send their transplant patients down to Henry Ford. So they're dealing with a select number of patients, but they're interested in keeping up with how the treatment is progressing as they're in our hospital, as well as any follow-up care from our nephrologists or our transplant surgeons. They also have the ability to upload documents into our Epic system through this web portal. Moving down into the 730 position there is Care Everywhere. And Care Everywhere is essentially the Epic system has some HIE XDS.B capabilities built into the system. It has the ability to send and receive CCD documents through these XDSB transactions. So it's both a push and a pull, but it requires a manual intervention. And we use Care Everywhere quite extensively, primarily with other Epic systems where we can communicate CCDs back and forth. We started with Cleveland Clinic, University of Michigan. We've got a number of health systems here in southeastern Michigan that are on Epic, Beaumont Health Systems and Oakwood Health Systems. And we're probably upwards of 100,000 of those CCD transactions annually to other Epic systems. Epic also talks about the fact that that same technology could be used to connect directly to Cerner systems, and the other health systems that don't have Epic in the Detroit area have Cerner, although we haven't been able to get that up and running yet. That Care Everywhere and the CCD Exchange is the technology that we use to connect to one of our HIEs, which is the Great Lakes Health Connect, HIE. And that's where we use the direct technology with Care Everywhere to send transitions of care documents to Great Lakes Health Connect, and they then shift it or ship those on to affiliated providers. Primarily at this point, it's our skilled nursing facilities. We've got a number of other physician practices that are big emitters into our various regional hospitals, and so that technology is used there. But that work was done primarily to get us ready for meaningful use stage 2 compliance. And then finally, in the, I guess that would be about 430 or the southeast corner quadrant there, is bridges, which essentially is your standard HL7 interfaces. So we have hundreds of interfaces that we have in place using EPIC's bridges, primarily to share data between our own internal systems. And these are push, event-based, event-triggered push transactions. We have hundreds of thousands of these transactions that flow through our interface engine every day. Those same transactions are being sent externally for certain use cases. We are sending those to our other HIE that we participate with, and that is MyHIN. So to MyHIN, we send immunizations that go to the state to support our MICR program. We send ADT data in labs to support syndromic surveillance and reportable labs. We send ADT data to which they then connect to Care Team Connect, which is used to support our statewide ADT notification system. And we are also in discussions with MyHIN at this point to send CCD also to do Social Security Administration e-disability work, as well as to CMS for requisitions for data. Moving on to the next slide. We have a convention at Henry Ford of starting every meeting with a patient story. And the reason that we do this is that it helps ground us in what we do. It reminds us of our mission in a very personal way, and it helps focus our priorities. So the patient story I'm going to share with you today came from about 15 years ago, where there was a primary care physician who entered his exam room to see a long-standing female patient of his, and this doctor also cared for this patient's husband, so he naturally inquired as to her husband's well-being. At that point, the wife broke down in tears and, through her sobs, answered that her husband had a medical emergency about a month earlier, was admitted to Henry Ford Hospital, and then died several days later. Well, obviously the doctor was mortified that all this had happened under our own roof with his patient, and the fact that he knew nothing about it. So that story galvanized us. So when we heard about that situation in our information technology department, we determined to do something so that that situation would never happen again. Now, Henry Ford, the automaker, was a pioneer, but Henry Ford Health System was also a pioneer. We earned a Smithsonian Award in 1997 for a software program that we developed internally called Care Plus. It was an early clinical data repository, one of the forerunners of electronic medical records. So Care Plus collected, classified, and stored patient information that was generated by tests, by doctor visits, by hospital admissions, and our doctors had 24/7 access to all their patients' charts as long as they had a PC with access to the internet. Obviously, these EMRs are nearly ubiquitous today, but they were somewhat rare back in the late 80s and the early 90s. CarePlus also had a physician inbox so that critical alerts could be pushed to the doctor, and it was fairly easy for us to write a function to push notifications to primary care physicians when we saw that their patients were admitted or discharged from or transferred between an emergency room and the hospital. These became known as ADT notifications because they were based on admit, discharge, transfer, HL7 transactions, which is the industry standard way of communicating these events. Once we implemented those notifications, we immediately began receiving compliments from our physicians. We heard how they would come into the office in the morning, log on their computers, and see a list of the patients, their patients that had been to the ER the night before, or who may have just been discharged from the hospital. It's one of the unique things about Henry Ford, because of the fact that of the large residency program and the employed medical group. At our flagship hospital, unlike in our community hospitals where a physician will see a patient in his office and then admit that patient and then go round on that patient while the patient's in-house, at Henry Ford Hospital, and I don't know if this is unique to us or if it's a common practice with other academic medical centers, but patients will be admitted and treated by inpatient physicians, typically hospitalists or residents, and there really wasn't much communication back and forth between those physicians and their counterparts that were out in the medical center. So this was an eye-opener for our primary care physicians to see and to be notified about the fact that their patients were either visiting the ER or had been admitted or had been recently discharged. And these notifications generated oftentimes or almost in every situation generated a concern call to the patient, conversation about the situation, and very often an appointment for a follow-up visit. Very frequently we heard that medications were changed and adverse drug events were averted as a result of that intervention, as well as potential readmissions were prevented. But over time, too much of a good thing became a problem. Doctors ended up spending more and more of their time on the phone with the patients, frequently unnecessarily, because patients might have been admitted to the ER for reasons that were acute in nature and were resolved by the time the physician called. And so by spending so much time on the phone, it reduced the time that they were able to spend with the patients that they were scheduled to see in clinic that day. So we enhanced the solution. We learned that almost all the phone calls could be handled by the nurses and the medical assistants that supported the physicians in their offices. So in an upgraded version of the electronic medical record, known as CarePlus Next Generation, we developed a group inbox for the primary care physician and his support staff and rerouted the ADT notifications there. This new approach enabled the office staff to contact the patient, conduct an interview, and schedule any necessary follow-up appointments. Any cases that they would triage these cases, and any cases that required a physician intervention that could then be forwarded to his or her personal inbox. Well, that approach worked well, but it did place an added burden on the office staff and took them away from the patients who were in clinic that day. So it was back to the drawing board again. The next evolution of ADT notifications was to create a centralized care management team that would handle all outbound calls for all of our Henry Ford Medical Centers. So all ADT notifications were rerouted to that group so that the office staff could then focus on the patients in their clinic, and the care management team also handled other types of patient calls. For example, calling patients, reminding them that they were overdue for appointments, overdue for tests, and then helping to get those things scheduled. When we implemented EPIC in 2012 and 2013, this same ADT notification capability was carried forward. However, we uncovered some unexpected patient behavior. We frequently partner with our payers, such as the one we own, Health Alliance Plan, and Blue Cross Blue Shield of Michigan, another one, to experiment with new ideas to provide more affordable and higher quality patient care. One of the programs that we participate in is called the Michigan Primary Care Transformation Program. And that underneath that program, they promote ADT notifications to primary care physicians as a way to reduce unnecessary hospital readmissions. So MyPICT creates and reports physician scorecards annually from information that they gathered from all of its partner organizations. And during the initial reporting period, the program manager from Henry Ford was surprised to discover that nearly 33% of the Henry Ford patients that were enrolled in this program had been admitted and discharged from hospitals that were not Henry Ford. And so the internal process that we developed was only catching 2/3 of our patients, and that was a huge surprise to us. But, you know, the reverse is also true. We see many patients in our emergency rooms and that get admitted to our hospital that see non-Henry Ford physicians for their primary care. So the bottom line is that we recognized the fact that what we had done internally was something that needed to be extended, and in order to really seal all the gaps, we needed to make sure that we had the ability to share information with every healthcare provider who sees our patients or with whom we share patients. So MyHIN came to the rescue. That's one of the health information exchanges we have in Michigan. It's participating in a statewide ADT notification service, and through an internet-based network of hospitals and physicians, it was able to replicate the benefits that we saw internally at Henry Ford across the state. They use a statewide physician directory that tracks communication preferences, and we started sending all of our ADTs to MyHIN in late 2013. By late 2014, we started receiving ADT notifications from other hospitals outside of Henry Ford. So here's the way it works. The patient presents into the ED or is admitted to the hospital, and they go through a typical registration process, which creates an HL7 ADT message. That ADT message will be sent out to the HIE that's connected to that health system, or directly to MyHIN. If the message in MyHIN will then get that message, check the patient against its registry of active care relationships. So all the providers are required to submit a registry on a monthly basis of all the patients that they have an active care relationship with, and then MyHIN bounces it up against that to get physician-provider attribution. And then it looks at their directory of physicians to identify delivery preference and sends the notifications based on that preference. Well, one of the questions that we wanted to address in the webinar today was how to make the decision for whom to solicit membership in the HIE. And I can only speak really from a provider perspective and based on experience of what we did. We started with the patient flow pattern. So we wanted to know who is referring patients into Henry Ford and to whom we're referring patients out. So ideally, the data flow should follow the patient flow. However, we realized that we had to prioritize around constraints. Not all of our healthcare partners had the same technical or operational capabilities that we had, and not all had the same willingness to change. I think Lauren mentioned the fact that there are a number of competing priorities, and I touched on the fact that our profit margins are extremely slim. However, where we found success was when we could align on incentives, and those would either be financial or strategic. So many of the financial incentives we were able to align on were meaningful use or some payer-based, some local payer-based programs. The strategic ones, we were in the process. I mentioned the fact that we've got a clinically integrated physician network. It's not a full-fledged ACO, but we're considering building an ACO, and obviously health information exchange is a key attribute for the success of an ACO. How does the ADT data assist the health plan? Blue Cross Blue Shield of Michigan about a year ago presented to the Michigan Hospital Association, and they were asked the same question. So I'm just going to basically copy what they said. Number one, and the reason I picked Blue Cross Blue Shield is that they are one of the key sponsors of the statewide ADT notification system here in Michigan. One of the three things that they mentioned, it was population health management was on the top of the list, improved care transitions and reduced readmissions. Obviously, we've talked about that. And then the other key point was meeting key customer expectations for pre-authorization. So the idea is for them with the ADT data, it's near real time. They know, just like our providers would know, when one of their members was admitted to an ER or to a hospital, and then they could rally their case management folks to work with the hospital to either transfer that patient if it wasn't a covered hospital, or to get the appropriate authorization for the admission. How do we benefit from providing the data? For me, it's really about cost benefit. So if I take a look at the cost to Henry Ford and what it took for us to do this work, ADT interfaces are easy. I mean, we do hundreds of them over the course of the last decades. So it was not a very huge lift to be able to create another ADT interface going outbound to an HIE. Because of the fact that we had that internal experience with our own electronic medical record, and we talked about the evolution of that we already had a care management infrastructure in place, and that was pretty key. So it's not just about exchanging data, but it's also about the human workflows that need to be in place to be able to deal with that data. And then we had the legal framework in place, so it really wasn't much to get that off the ground. The benefit, and this is primarily anecdotal, based on our own experience though, is that it nurtures patient engagement. So a patient recently getting discharged and getting a call from a care management, a physician assistant or a nurse practitioner, basically it helps to engage them in their health care. Certainly it improves outcomes. And although we couldn't document this statistically, our assumption is that it does reduce unnecessary readmissions. And just a point on that matter, it's somewhat difficult to build the business cases for these because there are so many confounding factors that play into readmissions and other and other outcomes that it's difficult to tease out one factor and say that it was the significant contributor. Can the ADT data be used for other purposes? And I'm just kind of blue skying here, but I do believe so. If we take a look at some of the data, the census data that's collected statewide, it's not complete. So from a statewide operational and strategic analytics, having a real-time ADT not only guarantees that the data is up to date, but also that we have data from all patients, because a lot of the data that's currently collected comes from claims, and claims can be weeks old. Claims are only going to cover patients that have health insurance, whereas with ADT it covers every single admission, irrespective of health insurance status. And the other point about ADT is that it is really foundational for any kind of clinical data repository. Any kind of record that you want to keep for a patient starts with having the appropriate demographic information and identification. So the next thing that we're looking at here in Michigan is a medication reconciliation, being able to share CCD information, transitions of care, CCDs that allow for medication reconciliation at the point of care. Another idea would be death notification. Sometimes it's difficult for us to update our records when patients have expired because they were somewhere else when that happened, and so we frequently send out alerts or notifications to them. Hey, you're overdue for an appointment or whatever, which is not very sensitive. And obviously, if we're going to have a community health record, and that could either be centralized or federated, it rests on the foundation of a good ADT. And one of the challenges that we've seen in doing this work is the fact that it's patient identification. There is no national single patient identifier, and so it's very difficult to, you try to use algorithms to pull certain key pieces of information from patient records to aggregate them into a single record, and you can only get so good with that. But that's one of the key challenges I would say we have. And that's it for me. Turning it back to Dr. Garland.
Thank you very much, Jack, for your presentation. So again, we have another 2 questions for you, please. First, states are creating prescription drug monitoring programs. If you could predict the future, what do you see in the future of an integrated HIE with the state PDMP? Thank you.
Oh yeah, that's a great question. And I know that one of the biggest complaints from my pharmacy colleagues is the fact that they have to turn away customers that they know got a script for opiates, or that's where they're frequent flyers. So I think there's 2 things that I know about physicians, and that is, number one, if you want to change physician behavior, you have to do it at the point of care, and it has to be pushed out as an alert or a reminder. And the other thing is that they don't like logging into multiple systems. So I would say that the best chance of really improving a prescription drug monitoring program would be to push out those alerts at the point of e-prescribing. And to whatever extent an HIE could facilitate that work would be very helpful. That said, I would think that most of the e-prescribing vendors, we use Dr. First before we went to Epic, and we know we've got SureScripts, should have the ability to get at that data and intervene with the physician at the point of e-prescribing. So I don't know if that would be more of a kind of a targeted use case that could be done there, and what role an HIE could play. But the bottom line is that the more that you can consolidate information about patients in a single place and make clinical decision support and other kinds of decision support rules and present those as part of the transaction that the physician is doing, the better chance you're going to get at physician adoption and physician adherence.
Excellent, thank you. Second question, sustainability means that states must identify customers for the HIE who will get a return on their investment. Merely more information does not always lead to a higher ROI. But hearing your presentation today, it seems as if you are successfully getting some ROI from your investment into the HIE. So kind of leveraging your rich experience, what advice would you have for hospitals attempting to measure the return on investment, the ROI, of their HIE?
I would say that it has to be connected to some strategy, that it's not about the HIE standing on its own, but it has to be the HIE as being the critical success factor of some other strategy that they're trying to accomplish. And that could be accountable care organization, that could be reduction of hospital readmissions, because it's not just, as you said, it's not just about sharing the data. What we found is that it really required the workflow redesign, and in some cases actually creating another standalone unit to deal with those notification transactions in order to be effective and to not disrupt the normal care that's going on in the clinics or in the hospitals. So basically that's what we experienced.
Excellent. Thank you. Thank you very much, Mr. Malloy. So our next presentation is by Carla Smith, Executive Vice President for HIMSS North America. HIMSS is a global, cause-based, not-for-profit organization focused on better health through information technology. Carla Smith, the floor is yours.
Thank you, Dr. Garland. And I want to thank Jack and Lauren. It's just been a terrific presentation so far, and I will try to live up to both of your excellent examples. So some of the things that I'm going to be covering in the remaining time that we have is to talk a little bit about the Meaningful Use Program and how health information exchange fits into that, highlighting the cost versus the benefit of health information exchange. How does HIE play into stage 2 meaningful use and what we see in the crystal ball regarding stage 3, and then planning for HIE sustainability. Now, I'm going to go off script for just a moment because towards the end of Jack's presentation, I thought it was interesting. He mentioned that one of the challenges that his team is facing, and certainly this is a challenge that all healthcare providers are facing across the United States and different places in the world, is the lack of a single way to identify patients. So I'm not going to spend too much time on this, but I did just want to let the audience know that there is work going on around this in regards to patient matching, of figuring out identity management in an environment in which the U.S. government is literally prevented from even researching these types of alternatives. Congress has prevented HHS from even raising this topic. In the private sector, there are efforts underway to explore what are some patient matching options. And so if you want to learn more about that, we could probably do an entire webinar on it, but certainly you can use the HIMSS website to see what HIMSS is working on, just to get up to speed a little bit on that, because Jack's absolutely right. It's a key issue that needs to be addressed. Back to our regularly scheduled program. Stages of meaningful use. So wanted to just highlight some of the themes by stage in the meaningful use program. Stage 1 was all around data capture and then the ability to create the ability to share data. Stage 2, the major theme is around advancing clinical processes and using to the best ability using advanced clinical processes. Stage 3, we anticipate, will be focusing on improving the outcomes of care, to improve both the quality of the care, the outcome of the care, the cost effectiveness of that care. Health information exchanges are critical to all stakeholders in the Meaningful Use Program, eligible professionals, eligible hospitals, critical access hospitals, in being able to achieve stage 2 of meaningful use. Because HIEs can facilitate meaningful transfer of data via structured and unstructured mechanisms, as well as improving the ability to coordinate patient care. And ultimately, HIEs can help develop the glide path to what we in the private sector anticipate CMS and ONC will be coming out with in regards to stage 3 meaningful use. One of the items that I wanted to highlight for the audience is just remember the audits that are possible here. All meaningful use attestations are subject to post-payment audits. Medicaid actually performs prepayment audits, and these prepayment audits do not exclude anyone, any meaningful user, from a post-payment audit. Also, the risk strata will change from year to year for the audit process. An audit for one program does not prevent your organization or an EP from participating in the current program year. So that has no impact there. So we want to make sure everybody understands that all information submitted with an attestation is subject to audit, and we recommend to keep all of your attestation records, any of the reports you've used, et cetera, for a minimum of 7 years. So the kind of information that you're going to want to be keeping are things like your eligibility data that you've reported on, the meaningful use numerators and denominators and where you got those from, exclusion information, and yes/no documentation around the measures. Now, you can see on this screen here the incremental approach from stage 1 to stage 2 for all the stakeholders. And you see in here how the percentages change for each objective as a stakeholder moves through the Meaningful Use Program. Between stages 1 and stage 2, often, but not always, the core objective percentages increase. And a new core objective was added to stage 2 that was not present in stage 1, and that is secure electronic messaging, which of course ties directly into an opportunity for health information exchanges to support providers in fulfilling the requirements around the Meaningful Use Program. You see on this slide how the shift has happened from stage 1 to stage 2. Again, you see the incremental approach here that the government is taking. In stage 1, these objectives were in the menu. In stage 2, all of them have moved to core objectives. And in some cases, the percentage has also increased. We anticipate this continuing to occur in stage 3. With the menu options included in Meaningful Use Stage 2, this is an example of the 6 menu set objectives, eligible professionals must report on 3 of the 6. Of them, notice that 5 are new objectives, and 3 are addressing the capture of information as structured data. So those include, the 3 that are new include electronic notes, the imaging results, and the family health history. And I've also had in the slide here the percentages that are required in stage 2 meaningful use. Also, just noting 3 of these are relevant to public health. Again, this all ties back to working with a health information exchange and able to have real-time data and data upon demand be able to be accessible in a secure and appropriate fashion. One of the things that we have learned through HIMSS Analytics, since 2007, HIMSS Analytics has been collecting census-level information on all hospitals, all civilian hospitals in the United States, in regards to their acquisition and implementation of information technology. And this data has been used to create and populate a model known as the Electronic Medical Record Adoption Model. Since we started this in 2007, it became very easy for us to sort of put a pin in the date certain of when the first meaningful use payments were made. At that time, in second quarter 2011, about 30% of U.S. civilian hospitals, and so when I say civilian hospitals, I mean those that are not military, not veterans, not Indian Health Affairs, but the other 5,000 plus hospitals in the United States, about 30% of them had virtually no information technology infrastructure. That's roughly around 1,500 hospitals. As of the end of December of 2014, that has decreased dramatically, and now only about 200 hospitals in the United States still have no discernible real use of information technology. So I just offer that up as a marker, and certainly we can provide more information offline for anyone who's interested in seeing those specific percentages, because we do make those freely available. So I use that as background so that you can understand better contextually this pyramid. This is the trajectory that the Meaningful Use Program is predicated upon. First, start with the HR adoption. Then once you have fairly widespread adoption of electronic medical records, then you are able to start moving upwards in levels of sophistication to actually get to that desired outcome at the top, which actually the word outcomes, and that is, what that means is that the outcomes of the care have improved, that the safety of the care has improved, that the cost effectiveness of the care has improved, and also the accessibility of the care has improved. So I've got a couple slides here on what is the value of interoperable data in improving health outcomes, and there are quite a number of potential benefits to get to that hoped-for outcome of improving healthcare outcomes. One is ensuring that more timely patient interventions can happen so that you've got the right information, excuse me, pardon me, so that you have the right resources in the right place at the right time to meet the needs of the patients that you are trying to serve. It also can support the practice of communicating and representing patient data so that it is both secure and reliable and understandable in the context in which it was originally created. Another value is that it can promote patient safety and improved outcomes because you have complete clinical information available to the clinician at the point of care. It can enable better outcomes due to secure electronic sharing of the data as a patient transitions from care setting to care setting into the home, being able to use smart devices in the home to keep a patient in the home, help them return to health, in a more effective way. It can also decrease the risk of error at the transfer of care points. You can reduce the need to re-enter data. That can also reduce error as an example. It can improve the patient's experience of the type of care that they got, their experience of their healthcare provider encounter. Can help ensure that they get the right care at the right time. It can also at least reduce, and in some cases eliminate, some costs, but hopefully reducing some of the costs by reducing or eliminating redundancy. It can also improve workflow and help increase the probability of having the right information at the right time in front of the right people. It enables better clinical collaboration. It enables better engagement with the patient, and it can help to support earlier interventions. There are 3 areas of focus in regards to health information exchange and meaningful use stage 2. In regards to transitions of care, this supports eligible professionals, eligible hospitals, and critical access hospitals in meeting the stage 2 data transport requirements that include things like the summary of care, the provider directories, and the eHealth exchange. It also can support the transport of public health measures and public health transmissions. So, for example, in many states, there are limited resources at the state level. So this is an opportunity to leverage the HIE infrastructure. HIEs can add necessary data facility code or filtering, and HIEs can also help the stakeholders in meeting the data transport requirements. So, for example, immunization transport requirements, electronic lab reporting, syndromic surveillance, cancer registries, infectious diseases. The HIE can help with all of those. And patient engagement. Providers can work together on patient engagement requirements that are listed in stage 2. And the HIE can also help with data transport in this area in regards to the summary of care, ensuring that the patients have it, making secure messaging between the clinician and the patient possible, and also to support patient education. At the top of the screen here, you see the word high-tech, and just a friendly reminder that high-tech is actually the name of the segment of the law. The Recovery Act is the name of the law, American Reinvestment and Recovery Act. High-tech is the segment of the law that specifically pertains to the healthcare sector. So I just wanted to make sure everyone understood that. So meaningful use stage 2 includes rigorous expectations for health information exchange, and we absolutely anticipate that stage 2 will increase the rigor around HIE requirements, including data capture in electronic formats, electronic data exchange capabilities, specifically around transmission and receipt, and structured data formats. CMS has already stated that any provider receiving an EHR incentive payment for either the Medicare or the Medicaid EHR incentive program may be subject to an audit, and I mentioned about how important it is to retain your records around that. If called for an audit, providers may only have perhaps 2 weeks to collect and submit the audit documentation, so you're going to want to have a good process and understand where your materials are. And providers can be audited up to 6 years following the attestation, which is why I earlier recommended that you keep your records for a minimum of 7 years. I wanted to highlight there is a resource available for you on the business case for interoperability and health information exchange. If you just Google business case for interoperability and HIE, you will bring it up. There's a PDF. that I hope you will find valuable. So some of the tasks that lie ahead for an HIE can be framed in ways such as this. HIEs can really help to improve the mismatch of regulation and policy that delay and sometimes hinder clinical interoperability needs. Sometimes public policy, though well-intended, when you get to the boots on the ground level, does not help and can get in the way. A second one is to help define a clear path to a data economy. What that is that's an ecosystem where data is liquid, so it can flow easily, but it is protected so that there is appropriate security protocols around. Another webinar that you could have a fabulous conversation around is, for example, on cybersecurity. We now live in a world in which nation states actually are working on hacking into the U.S. to various U.S. health providers. Anthem is an example of an organization that was recently hacked. So the protection is paramount here. Another one is correcting the perception of HIE as a financial overhead. Instead, build alignment of health information exchange into new payment models, and I've got more to say on that around sustainability. And then ending the use of proprietary architectures and to allow innovation to accelerate so that you have a better flow of more liquid yet protected health data. So let's talk about planning for sustainability. ARC, AHRQ, and I have the URL right down here on the screen, has a terrific resource that you might want to look at. It's the Guide to Evaluating HIE Projects, and it talks about financial sustainability and a sound business plan. There's no one proven business model that is appropriate for all health information exchanges. I'm sorry, I wish I could tell you there was, but there isn't. When you've seen one HIE, you've seen one HIE. There are many unique nuances depending upon state law, local law, various governance issues. So what are some ways to successfully address sustainability of an HIE? Well, certainly one is to identify the market needs, to identify a use case that aligns with the immediate needs to the region, and that to recognize the unique regions or unique needs of that region. And let me give you an example. In Vermont, Vermont has a three-pronged strategy for sustainability. And those three areas are, one, deriving commercial value from existing services. Their second one is that they provide fee-based data services for healthcare organizations, such as data transport and analytics. And third is expanding their services to potentially include things such as consulting, medical image archive storage for hospitals, and connecting to neighboring health information exchange organizations. Both Mississippi and New Hampshire, in addition, see value in continuing to build out their query-based exchanges because their stakeholders are seeing an increasing need for establishing robust query-based exchange. So those are just some examples of understanding your local market. A second component is to consider the appropriate revenue model. There are at least 4 revenue models to consider. One is a membership model, in which the HIE charges a set rate for an organization that wishes to participate in the exchange. This fee-based model is often tiered and based upon the size of the organization. And in this model, every organization is expected to pay a fee to participate, so pay to play. A second model is a transaction fee model, in which the participants pay a fee for the transactions as they utilize their health information exchange. A third is a tax-based model. Some states are planning on levying a tax on every health insurance claim transaction processed within the state. The revenue generated by that tax will be used to support a single statewide HIE. An example of a state that is already doing this is Vermont. And a fourth revenue model is a subscription fee model in which the HIE packages its services into offerings and provides them both individually as well as packaged on a subscription basis to their users. This model, by the way, is more common in more mature HIEs, and there are some examples that I can share with you of subscription fee models. For example, Iowa, New Hampshire, Mississippi all use annual subscription fee schedules that vary by stakeholder type and size. Utah has a three-pronged model where insurers, hospitals, and providers each pay 1/3 of the HIE's cost. Another component to keep in mind here in sustainability is leveraging interstate exchange and infrastructure sharing. Many patients cross state lines to get care, and so this is something important to be paying attention to so that you can track referral patterns and leverage shared exchanges. Providers often find value in this idea because it furthers the goal of creating a healthcare system in which the records follow the patient, and certainly patients value this highly. An example is the Mid-States Consortium, which was started between Kansas and Colorado to handle the quantity of patients that were crossing state lines to get health care. Sharing an HIE infrastructure can lower the startup costs and could increase the return on investment for HIEs that use this. Another component of sustainability is to utilize your policy levers when they're applicable. Specifically looking at ACOs, that's often a cornerstone of sustainability for existing HIEs. And I think Jack mentioned ACOs and the connection to HIEs that make ACOs possible during his presentation. Because ACOs require infrastructure in order to effectively and efficiently become an ACO, and HIE becomes very important. Now, working towards payer engagement, this is another key component of sustainability. For continued funding to sustain an HIE and its services, actively engaging the payer community is very important. Use cases include things such as case management and reducing utilization. Also, HEDIS reporting for Medicare Advantage programs is another example of what some state-designated entities have utilized so far to bring payers into the conversation and engaging them in the HIE. Payers are increasingly coming to the table specifically for access to clinical data and access for pre-authorization for Medicaid. For example, Utah has a three-way model for funding its health information exchange. The insurers pay 1/3 of the total cost of the HIE, hospitals pay another third, and clinicians in the ambulatory space pay the final third. Dr. Garland, I realize that we are nearly at the bottom of the hour, and so I would like to pause to turn it back over to you to close the webinar.
All right. Greg, if I could seek your consultation quickly, what do you advise?
You can go ahead and follow up with your two questions to Carla.
All right, wonderful. So thank you, Carla, for your presentation. I wish we had more time. You've highlighted an extensive listing of benefits for interoperability. What advice do you have for states seeking to present these benefits to and have conversations with private payers specifically, as they can be vital stakeholders for sustainability?
Yeah, they certainly can, Dr. Garland. You're absolutely right. So what states can do, so that includes states that run HIEs or health information organizations or the public health departments, what they can do is they can reach out to the private and public payers and encourage them to participate in governance and advisory meetings for the state or the regional HIE to help the payer community better understand what services an HIE offers and how the payer could derive benefit from participating in the HIE. Also, many existing HIEs across the nation have a multidisciplinary board already set up, and ensuring that the payer voice is welcomed into those conversations is a terrific way to engage the payer and to turn the payer into a champion of an HIE. Payers can definitely see the participation in HIE organizations as multiple opportunities. It can improve their ability to undertake quality and performance improvement programs, because then they would have access to clinical data of their covered members, because that's available through the HIE. Another key benefit for payer involvement in HIEs is to benefit from reciprocal data flow, which can be very difficult to be doing independently. And then with the full participation of all stakeholders, including the payers, the HIE itself has a better chance of measuring improved health outcomes for the population that HIE serves. And that is tremendous value to the region, to the state, in helping to improve the quality of the health for all of their residents.
Thank you, Carla, for a thorough answer.
Sure.
Number 2, interstate and regional HIEs are emerging as a means for leveraging economies of scale and preventing redundancies in infrastructure. Amidst this consolidation, how do you advise various groups of clinicians and hospitals on the topic of data ownership? Who owns the patient data?
And that is, as they say, the $64,000 question. Who owns the patient data? That is hotly debated within the health sector. And so, rather than me giving you a single answer on who owns the patient data, I want to offer some guidance and thoughts for how HIEs can work through this very difficult issue. Each health information exchange should have a data governance policy, and that data governance policy needs to include data sharing agreements. And there are multiple types of data sharing agreements. What they are is that the stakeholders and the entities that are involved in the HIE agree on what data is going to be shared, who gets to see it, under what circumstances, what happens to it after it's been viewed, etc. And that is a terrific and very needed conversation within the HIE, and all of these stakeholders need to be able to agree. So there are different kinds of agreements that can be used. There's data use agreements, there are data use and reciprocal support agreements, there are business associate agreements, and there are participation agreements. Any of those can be harnessed, again, because HIEs are so unique and so specific to the region or the state that they're serving. It's wonderful that these different types of data sharing agreements are available so that the HIE and its stakeholders can work it through together.
Wonderful. Thank you so much, Ms. Smith. So we had planned to go into about 5 questions where we would open these questions for the entire panel to give feedback. So I'm presuming that we still have enough time and there are no objections, then we shall continue. If you could please just provide your response, if you like, voluntarily, and please keep your answers more brief. Thank you. So first of 5, discuss your experience thus far with transitioning from ONC-sponsored HIE to community-sponsored HIE. Anyone can step right up to the mic.
Well,
Yeah,
speaking
Dr.
for Illinois. Oh, go ahead.
No, Lauren, all I was going to say was from HIMSS's perspective, I'm probably not the best one to answer this question.
Well, and really in terms of our experience, because we have really not been sponsored by ONC funds, it's really kind of a difficult question for us to ask. But I think Carla did a really good job of pointing out the sustainability factors that are going to come into play once the grant funding is gone.
Wonderful. Thank you. Secondly, please differentiate between the various types of HIE models that you are seeing, hospital versus outpatient, public versus private, and how they can work together. You've spoken to this previously, but if you would, please differentiate between these various HIE models that you're seeing.
Sure. Dr. Garland, this is Carla. I'll be glad to take a first stab at this one. So there are currently three kinds of health information exchange. There is direct exchange. Think about that as push. That's used by providers to easily and securely send patient information such as lab orders, results, patient referrals, discharge summaries is another example, directly to another healthcare professional. And this information is sent over the internet. It's encrypted, it's secure, and it's shared between care providers who already know each other and trust each other. And you can sort of commonly compare this to a secure email. A second type is query-based exchange. A way to think of that is pull. That's used by providers to search and to discover what clinical sources are actually discoverable on behalf of a patient. And this is a type of exchange that is often used when delivering unplanned care. A third type of health information exchange is consumer-mediated exchange. And what that means is this is an exchange that provides patients with access to their health information. It allows them to manage their health care online. Oftentimes this is offered through a portal or through an app.
Yeah, and this is Jack from Henry Ford. I think it goes back to the strategy that we have for data sharing, which is fire in all directions. I mean, basically, these different models are appropriate for different sets of use cases. And, you know, if you think about the way that information was exchanged prior to being digital, it was pretty much the same way. Whether it be a fax or whether it be a phone call, it is basically these same three models.
I agree with Jack. I think it's really important that you share with as many sources as possible. And while Epic is a really good example of a private HIE and its ability to communicate then between other Epic users, there is some differences in the instances and builds between health systems. So I think health information exchange is pretty important as a not-for-profit organization to help even those customers communicate effectively with each other.
Wonderful. Thank you each for your responses. Should governance models for HIEs entering their next phase be managed by state government agencies, a community-led private organization, or a hybrid model? If you could provide any advice or a recommendation, you know, what type of organization should lead the consolidation, shall we say, of these various HIE networks?
Dr. Garland, I'm not sure there really is one solution, and I know there's no magic bullet. But I do think that there's important considerations to keep in mind. One is the state needs to have the right stakeholders at the table. And so those right stakeholders need to represent the healthcare sector, the policy sector, the technology sector. Certainly the patient's voice needs to be included in there. And to kind of figure out what are some of the common themes around governance, you know, multidisciplinary, probably not-for-profit status, those kinds of things. But each state has got some different regulations, and it's got its own set of laws that can really impact. So one model that works in one state may not really be able to work in another state. In general, I think that the best governance model is a hybrid. So it represents your cross-section of all of your stakeholders, that you're focused on the triple aim, which is healthy patients, of course, at a lower cost with higher quality.
I would have to agree with that, Carla. I think the hybrid model is probably more easily managed. I think it does include all stakeholders, or has the potential to include all stakeholders. This is kind of a loaded question for Illinois. I think we've had a lot of trouble coordinating some of our activities. So I think a hybrid model is one method to address those challenges.
Wonderful. Thank you. How would you advise states to access any federally or state-sponsored programming to use the HIE infrastructure for managing super utilizer or high-use patients and those populations? How would you use HIE for managing the high-risk, high-cost, complex, high-need patient populations?
Sure, sure. So those patients that have, for example, multiple or chronic conditions, the diabetic patients, emphysema, heart failure, behavioral health that have comorbidities, right, absolutely, totally understand that. So some of the things that a health information organization infrastructure can offer are things like core data elements, medications, the procedures, the diagnoses that are needed for a data warehouse. Also, another one is a system-generated identifier that could be used to link patient data across the various institutions that the patient has engaged with. If patient-level linking isn't required, then perhaps the summary quality measures from individual institutions could be aggregated at the HIE level. That's not going to risk patient privacy, so that's something that could be considered. And certainly looking at syndromic or clinical surveillance to help drive decisions at the public health or health policy level could be very helpful.
Wonderful. Thank you. Thank you. Can the HIE be used for research, either academic or even commercially sponsored research? Or are the security risks too significant, too great?
I do agree that research does require a higher level of security, and very frequently, at least within Henry Ford, patients will allow us to use the information for treatment or for care and sharing with other organizations for those purposes, and then opt out for research. However, that said, I think my bigger concern would really be the completeness of the data. I can see 5-10 years that there'd be enough data in the HIE to support the level of research that are typical of the sorts of things we do at Henry Ford. But based on the way that we are sharing data today, I would say we're not there yet.
I think Jack's spot on.
Wonderful, wonderful. So now, I'd just like to, I guess, stop and say now that we've heard from all three presenters and answered all questions, I wanted to wait until the end to just say, wow. Each of you have made simply phenomenal presentations, and it's been a real treat to hear from each of you today, Laura Wiseman, Jack Malloy, and Carla Smith. The great benefit, I think, of these presentations today is that we get to hear the best practices and emerging best practices that are being developed in states across the country. And not only has this been educational, but it's also inspirational to know and realize that all the work that we've been putting forth in our respective states across the last few years, over the last few years, is being given as much thoughtful consideration by other experts, yourselves, across the country. So again, thank you, Laura Wiseman, thank you, Jack Malloy, and thank you, Carla Smith, to each of you for your presentations to us today. And thanks again to Greg Wahlstrom, who I will now give the remainder of our webinar today back to him.
Thank you, Dr. Garland. Now we would like to open up the floor to any questions or answers from the attendees. On the left-hand side of the webinar platform screen is a text box to write a question to the presenters. If you have a general question, please insert your question into the text box. And if you have a specific question for one of the presenters that you would like to ask, please insert his or her name next to your question. At the end of today's webinar, you will be directed to a short survey which the Central Illinois chapter of ACHE hopes you will take the time to fill out to help with future planning. So the first question that comes to point is, how are you ensuring financial sustainability in order to keep operating?
Well, this is Lauren from the Central Illinois HIE, and I guess I'll try and answer that question. It totally is a challenge to make sure that we have the funds available to continue operating, as well as expand the services to provide even more value to our customers. So there really is a necessary to have a multi-pronged approach to this. You know, to understand what your underlying costs are, to allocate those costs over the entire membership in a way that's fair, so that you can obtain the data from the small providers, from your critical access hospitals and your FQHCs that couldn't otherwise participate. And I think that you have to plan for the future and look to other types of vendors that may be able to help you provide services with, for instance, image sharing is a consideration that we have on the table right now, which doesn't really cost the information exchange, the HIE, anything to provide, but it can be offered to our customers and provide them a little bit more value without any outlay on our part.
Thanks for sharing, Lauren. Jack, this is a specific question addressed to you. Could you tell us what were the major reasons for going from the legacy systems to Epic?
We realized that we just didn't have the development staff that could keep up with the changing regulations, and especially with the high tech, and that there was just no way we could keep up. Plus the fact that we had looked at Epic back around 2000, 2001, and it wasn't as mature or as robust as what we needed. Being not only a set of hospitals, but also a medical group, we had requirements on the revenue cycle side to do both professional billing and as well as institutional billing, and we had a long legacy of doing that in a combined fashion with a consolidated patient statement. And then on the clinical side, there were a number of things we had in our electronic medical record that Epic didn't have at that point. And basically the market matured, and Epic not only came up to what we were doing, but far surpassed us. So it only made sense.
Thank you, Jack. This question was addressed to the entire panel. Have you integrated public health databases and registries into the Health Information Exchange data flow?
We're not currently doing that in Central Illinois.
Some HIEs across the United States have been able to successfully engage with their public health department, both at the state level and at the local level.
And one other question. We're doing that in Michigan in just a one-way fashion. We're sending the immunizations into the Michigan Department of Community Health.
And one other question coming across is, how can we present a best practice HIE sustainable model around interoperability, care coordination platform with focus on high risk and high cost populations?
Perhaps the the key would be to align with the accountable care strategies and focus on the high utilization patients and try to communicate and utilize the HIE data to provide care across the continuum and make sure that patients actually have the resources that they need in order to manage their complex diseases.
I completely agree with Lauren, and I think it's important that HIEs gather information not just from the providers but also from the payers as well. That we see that as you know, a way to fill in the gaps, getting information from providers that don't have the capability.
And one more question is, do you think that we are going to see health information exchange in different languages across the United States?
Gosh, I hope not. Yeah, as Carla said, there's different models, there's different funding approaches. You know, if you've seen one HIE, you've seen one HIE. Lauren said the same thing. It would be great if we could get to, you know, at some point, the level of maturity where we've got consensus around the best model. It would make my life a lot simpler.
Yeah, I think that's a really interesting question because certainly in the United States there are many languages that are spoken and a few, you know, obviously Spanish comes immediately to mind. And then you have parts of the United States, for example, such as Puerto Rico, where predominantly it's a Spanish-speaking environment. And then you've got regional areas where there are high levels of different languages that are spoken. At the HIE level, I haven't heard of in the United States, of a non-English primary language HIE. I think that's a really interesting question. I'll be curious to see how this evolves as we continue through time.
And I just want to end with one last loaded question. If you could address why there are multiple health information exchanges in Illinois compared to a single statewide health information exchange that you would find in Georgia or North Carolina or Pennsylvania, to name a few, it would seem that there is an unnecessary cost and duplication of resources with multiple health information exchanges. It could also cause difficulties in connecting to and sharing information with neighboring state health information exchanges. For example, Georgia and South Carolina have connected health information exchanges, which they are finding it to be beneficial for clients across the United States and across state lines of care.
I totally agree that that is a loaded question. But I really believe that the answer lies in the fact of how late Illinois was to the health information exchange discussion and commitment. I think that it is challenging to address the needs of a large metropolitan area and then look at the rural areas that exist within central Illinois and the southern regions. And you know, you have another metropolitan area bordering Missouri. I think it's really important that eventually we get to the point where all of the exchanges are talking to each other, whether that's through a single hub that is the state Illinois or a state exchange, kind of like the Michigan model, or you know, even to be able to have one connection then between state to state. It's going to be challenging to make that happen, but I do hope we see that in the future.
Mm-hmm. You know, this is Doug here. Greg, we also in Washington, D.C. have multiple HIEs. There are public and private HIEs, hospital HIEs. You know, with the Healthcare Innovation Awards, round 1 and round 2, there are new HIEs emerging, sometimes kind of per each grantee recipient. So the Department of Health. So our HIE is actually kind of administered and managed by the Medicaid program, or the department that manages Medicaid. But the Department of Health also has an HIE. The Department of Behavioral Health, they receive a lot of kind of funds and sponsorship from FHIMSS. also has an HIE. So we have several HIEs in Washington, and indeed the the next steps where we are moving is not just a kind of an integrated, but a useful integrated HIE that will help to improve patient care and care outcomes.
And we're seeing consolidation of HIEs in Michigan. The two largest HIEs, Michigan Health Connect and Great Lakes HIE, merged last year, and I anticipate seeing even more of that in Michigan. So I think the trend would be, and it's all due to financial sustainability, more of a consolidation.
As we conclude today's webinar, we would like to especially thank today's moderator, Dr. Douglas Garland, and our presenters, Lauren Wiseman and Jack Malloy and Carla Smith, for taking the time to share pertinent information about health information exchange and the impact that it has on our healthcare organization. The Central Illinois chapter of ACHE will be holding another webinar on Monday, April 13th, 2015, from 12 to 1:30 Central Standard Time on physician-hospital integration in the 21st century, worth 1.5 hours of qualified education credit through the American College of Healthcare Executives towards your board certification or recertification. We would like to thank each and every one of you for taking the time out of your busy day to attend today's webinar. Make sure to log into your ACHE account to record your 1.5 hours of qualified education credit for today's webinar. And this will conclude today's webinar.
Thank you.
Thank you.
Thank you, Greg. Bye-bye.